I'm going to quickly touch on the rehab, and again, trying to throw 3 different procedures in here. So just very quickly, in terms of patellar dislocations, this was actually a study done in Olmsted County, Minnesota. They actually did a 21-year study, and basically, again, the highest incidence, 14 to 18-year-olds. They actually found that males and females were equal, but in most literature, females more so than males. But again, they basically concluded a higher incidence they were seeing than what has been reported. In terms of surgical versus conservative, the first article, 1982, is when I graduated college, so this was good stuff. I could come out of college, treat them conservatively, and these patellar dislocations did great. I was going to cure the world. The problem is when you follow these people up, there's up to a 50% recurrence of dislocation, so wasn't doing very well with the rehab. So in terms of surgical versus conservative, the pendulum is turning more and more toward the surgical type of treatment. And again, the MRIs and what we're seeing, what's happening with the medial patellofemoral ligament. So the medial patellofemoral ligament, it is the major static restraint for the patella, up to 53%. I've seen in some cases even 60% it requires. The problem is after our first time lateral patellar dislocation, the MPFL has been reported to be damaged up to 90% of the time. So there's the problem with that ligament being damaged. So this is where, again, with the ligament being damaged, a lot of times Dr. Juleson will do this reconstruction, and again we go on with rehab. Now, if it is just a straight medial patellofemoral ligament reconstruction, we can go pretty quickly with these. These guys are locked in a brace initially the first week and a half, non-weight bearing to even half weight bearing, but realizing that just weight bearing does not hurt the medial patellofemoral ligament. It would be the weight bearing with twisting, and so that's what we have to watch with these folks. And again, we try to make sure they have a good quad muscle. Weight bearing will progress almost at 3 weeks, almost a full weight bearing, and we're really going to emphasize this core strengthening that Dr. Juleson talked about. And we've really found this in the last several years now, that this is going to be the key with these folks. And again, the protocols are all on the jump drives that we do have supplied with everybody, and we do try to update these every couple of years. We do expect full range of motion, and realizing that the medial patellofemoral ligament is actually taught more so an extension versus flexion. We do have a criteria that in terms of returning to high-level activities, we do a strength assessment with these guys, and then we do have return to sport criteria. Now, just very quickly why we hit the core again. In terms of a lateral patellar displacement, A is a open chain activity, and this is where the femur is fixed. They're doing a long arc quad. This is a person with lateral patellar subluxation, and you can see how the patella tilts laterally. In B, this is a closed chain squat activity. You can actually see that the patella stays fairly level. It's actually the femur that's rotating underneath the patella. So functionally, we're actually seeing the femur move versus the patella. And this is actually seen when they've measured hip strength. And again, females with patellofemoral pain, look at that hip external rotation strength, almost a third weaker. They actually did a comparison in here recently in the International Journal of Sports Medicine, saying, let's look at men or males compared to females, and do they have the same deficits? And actually what they're seeing with males is it's more so the hip extensors showing the weakness, versus females, it's the hip abductors and external rotators. And then again, just another study showing how the femur rotates internally, and just hard to stop that. So again, we do a lot of core strengthening. Miranda hit that very well yesterday, and again, very important for our rehab. In terms of return to play criteria, if you look at several protocols out there, basically a study done here recently, only 20% of them really had any return to play criteria. So that's also an issue again, as we get these people back to sport. What are you using to give them safe return to their activity? So in terms of distal realignment, this is where, and again, Dr. Juleson can pipe in any time, but we basically have two types of tibial tubercle transfers. And this is one I really have to talk to Dr. Juleson and Jeff Hilzenegger in regards to how well we're doing. So with the LC Triot, that is one we're going to just move it medially. And these ones we tend to be able to go just a little bit quicker with. So this is one, they are an immobilizer, lock and brace and extension, but the first 2 weeks, we're really only toe touch, 25% weight bearing at the most. And then not until we get to almost 6 weeks post-op that we progress full weight bearing, okay? So for just medializing the tibial tubercle, again, weight bearing to full probably till 6 weeks. We're gonna progress with range of motion, and the quads will go slower. We are watching the patellofemoral joint, again, really working with knee extension 90 to 30 degrees. And again, these protocols will be in your jump drive. The Falkerson procedure, or the AMZ, now this is just a bigger animal. And this is one where Dr. Juleson will talk about getting in more of the posterior cortex, and this is one where they are going much, much slower with weight bearing. And again, this is also called the AMZ, the anterior medialization transfer. And this one, they will be locked in their brace. It could be 8 to 12 weeks. And again, non-weight bearing 6 to 8 weeks, and this is one that I have to wait for the green light before we do a progressive weight bearing program. We're going to go the same with range of motion, just very slowly, very submaximal quads. And again, non-weight bearing or to toe touch 6 to 8 weeks. So they again are just much slower. And then progressing a progressive weight bearing program. And a lot of times a progressive weight bearing may be only 25% per week. So again, much slower. So again, definitely when you ask for the protocols, you get these patients, which tibial tubercle transfer is it? And again, we got to wait for that weight bearing progression. So in summary, watch the procedures. A lot of times these medial patellofemoral ligament reconstructions will be done with the distal realignment procedures. And because of the bony portion of that, we have to go much slower with the weight bearing, much slower with our quad rehab, and much slower with the range of motion. Hip strengthening, again, is just very, very important. Again, Miranda hit that very hard yesterday. And then the return to play criteria, which Miranda will also talk about this afternoon. Thank you.
Just a couple comments on that. With the medializing tibial tubercle osteotomy, we've actually evolved a little bit to go a bit more aggressively, so the patients can bear weight on that knee with a locked in full extension based upon comfort level. And so then with the anteromedializing, because it involves more of the proximal tibia, there is an early about 2 to 4% tibial plateau fracture risk, and that's why, as Kevin alluded to, we're more cautious on weight bearing. So that's been shown in multiple large center studies that people are having fairly disastrous complications by early weight bearing with that. So we definitely avoid full weight bearing. The third part is a distalizing tibial tubercle osteotomy. Those take longer to heal than both of those previously mentioned. So that's the other thing to just check those off notes, because depending upon the patient's malalignment, we may have had to have corrected them in 3 different planes. So just check those off notes. Every single one of these is unique and individual.